Thank you. So you all know natriuretic peptides are as gold standard biomarker in heart failure. And biologically, those natriuretic peptides also have many beneficial effects to mitigate the effect of heart failure. And from a metabolic standpoint, they are all synthesized as a pre-pro-NP. The signal peptide is removed, and this signal peptide is important because its metabolism is completely independent from the rest of the peptide and can be used as a surrogate of production. The resulting pro-NP can be heavily glycosylated and will be cleaved into the N-terminal fragment and the major peptide. The major peptide will produce cGMP via its receptor NPRA and can be also eliminated by protease such as neprilysin. And because of the beneficial effect and because neprilysin is known for a long time, one way to potentiate the effect of natriuretic peptides in heart failure is to inhibit neprilysin, and this is the case with sacubitril valsartan, also known as Entresto, who showed improvement in heart failure with reduced ejection fraction. But Entresto came with a poisonous chalice, which is that BNP increased after initiation of the treatment while anti-proBNP decreased. And we found the exact same thing, is that BNP remained stable while anti-proBNP decreased, which was quite unconventional. And based on this result and the various hypotheses that were drawn to explain those differences, we decided to take a deeper dive into the metabolism of natriuretic peptides and also as biomarkers. So most of what I'm going to show you relies on 73 patients with FRF who were switched to Entresto, and we have 3 time points before and a month and 3 months after initiation of the treatment, healthy volunteers. We measure BNP with Abbott, anti-proBNP with Roche, and MR-proNP with a cryptor assay, and we also use various flavors of mass spectrometry. So first of all, from a physiological, pathophysiological standpoint, FRF is a major ANP defective state, and to cut a very long story short, what we found that in FRF, pro-ANP production is limited, corin activity is decreased, which overall leads to a lower than expected production of ANP, and Entresto completely reverse and enhance this via 3 mechanisms. First of all, pro-ANP production increases, pro-ANP cleavage increases as well, and ANP half-life is increased because it's no longer degraded, leading to a 4 to 5-fold increase in ANP. When it comes to BNP, the situation is slightly different because here you have proBNP, you have the signal peptide, you have the anti-proBNP, the molecule, and furin activity. And what you can see is that everything is higher in heart failure as expected. And when you put sacubitril valsartan, we just observe a slight increase in furin activity and a bit in anti-proBNP production. When it comes to BNP itself, normally in many species, neprilysin should have cleaved here, but in human it cleaves here to produce BNP 532. Once again, kind of as expected at baseline, BNP 132 and 532 are higher in FRF compared to control. But when you block neprilysin, you obviously lose 532, which results in increased level of 132. And this is important because BNP 132 is a very good activator of the receptor, while BNP 532 isn't. So overall, FRF is probably not a BNP defective state, although Entresto improved BNP cleavage and BNP activity. So now we know that. How does it translate into biomarkers? And a major problem with natriuretic peptides is glycosylation, because glycosylation can mask epitopes, and therefore you don't measure exactly what you think you do. If we look at MR-proNP, so these are the 3 molecules that can be detected by the assay. You have the 2 epitopes here, and one of the epitopes can be glycosylated. And when we measure MR-proNP in this cohort, you can see that it decreases after the initiation of the treatment. But if we measure the signal as it should be, if there was no glycosylation, you see that the biomarker should have increased. The reason it decreased is because glycosylation increased as well. So you have increase in the signal, you have an increase in the interference to the signal, which is greater, and therefore you have a decrease in the result. And also, we looked at MR-proNP versus the signal peptide pro-ANP and ANP, and there is absolutely no correlation whatsoever. NT-proBNP is exactly the same story because you have here the two molecules that are recognized by the antibodies, and the epitopes in orange. One is glycosylated, and we have the exact same story. NT-proBNP, as I showed, decreased, while the signal should have increased, and the reason for that is that in both instances, the glycosylation increases and therefore mask part of the signal. BNPSA is different because, as you can see, there's no site of glycosylation, so BNPSA are insensitive to glycosylation and mostly detect proBNP, full-length proBNP. So now what we looked was, how does that compare when it comes to the production itself? So we looked at BNP assay versus proBNP signal peptide as a kind of surrogate independent measurement of production. And as kind of expected, it correlates very well. But to have very, very big surprise, and to the cat's surprise, NT-proBNP performed better, overall, and also across the clinical landscape. Here you have control, you have FREF plus or minus Entresto, you have acute heart failure, and you have acute dyspnea of non-cardiac origin. So both are very good surrogates, but NT-proBNP seems to be more consistent. And of note, because there were debates, in FREF, BNP and NT-proBNP are equivalent. As a kind of conclusion, I would like to give you two messages. The first one is the metabolism of ANP and BNP is way more complicated than we initially thought. And acute heart failure, and that's data I presented at a great meeting 10 years ago, is possibly the most optimal BNP state, and we don't know for ANP, while FREF is clearly ANP defective state with BNP unclear. And Entresto reverse this defectiveness and also enhance the system. So now we know that are natriuretic peptides still good biomarkers? And the answer is obviously yes, because they were defined as measurement able to discriminate between different populations, irrespectively of metabolism and biology. And also, if you interpret your BNP and NT-proBNP result as a surrogate of proBNP production, it's still true. However, what you can't do is to draw any biological interpretation from MR-proNP, because in the end, we don't know what it is a surrogate of. And also, if you want to interpret your data in terms of how much natriuretic peptide is active, our data suggests that you can't do that as well. And as it said, and if you do, the cat will be judging you. Thank you.
Thank you so much for your presentation. Is there a question from the audience? I actually have a question. You were talking about you call it the theoretical concentration, so what glycosylation is not a problem with your NT-proBNP assessment. I saw like an abbreviation, or how are you sure what the exact NT-proBNP concentration should be when the glycosylation is not interfering? Can you explain to me?
So what we measure using mass spectrometry, so we measure NT-proBNP. So it's capillary electrophoresis coupled mass spectrometry, so we know the length is correct, and then we can measure. So we measure NT-proBNP based on a fragment that is not glycosylated, and then we measure glycosylation by LCMS. So we have the amount that is glycosylated, the amount that is not glycosylated, and that's how we...
Okay, that was not, that's clear now, and I can see someone of Roche is still in the room, so your suggestion is to adapt antibodies in the current assay, or what is your message to Roche?
I have no message really, but no, the thing that is absolutely incredible with the NT-proBNP assay, and that was really surprised us, is so you have a measurement that does not reflect really what's going on, because NT-proBNP, for instance, decreased, while in reality it should have increased. But the thing is, at the time the assay was developed, glycosylation was not known, and nobody tested the signal peptide. And despite that, and by kind of pure serendipity, you have a biomarker that performed better as a surrogate of something that it shouldn't have measured than BNP. So I think that given the current state, things shouldn't be changed. So yeah.
You said that you very elaborated study based on 73 patients, so you deep characterize this group. Do you think that this group is overall representative for the, let's say, scope of heart failure, or do you think there could be other constellations, other patients with different patterns?
So, I mean, compare, for instance, to Paradigm. The patients were slightly worse. They were more NYHA3, for instance. But when you compare it to other studies, for instance, Jim Januzzi sampled different BNPSA, and discussing with them, basically we have the same kind of trends overall. And also, I mean, these are just a part, the tip of the iceberg, because we have measured more than 100 different parameters, and all the time everybody is kind of, the variation are quite consistent across the cohort. So we think that even though it might not reflect every single cohort, it's still reflective of the metabolism that will occur in any patients.
Okay, any further questions? No? Okay, thank you very much.